So now I will introduce you to Dr. Diane Harper, who will moderate the webinar and assist the panelists with any questions or comments. Dr. Diane Harper is an internationally recognized clinical research expert in HPV-associated diseases and their prevention, early detection, and treatment for the prevention of cancer. She has been a consultant for the World Health Organization and the Pan American Health Organization to advise on global guidelines and to set up screening and prevention operations in low and middle income countries to prevent cervical cancer. She received the Distinguished Scientist Award from the European Research Organization on Genital Infection and Neoplasia for her scientific work, as well as the Femme de l'année Prix Monte Carlo, which honors one local and one international woman a year for her influence in bettering women's lives around the world. Diane joined the instructional track here at the Department of Family Medicine at the University of Michigan Medical School in early 2018. Diane, the floor is yours.
It's my pleasure today to introduce Dr. Michael McKee to you. He is a family physician with clinical and research expertise in disability health. As a physician with a hearing loss, he is especially interested in advocating for the rights of those with disabilities to obtain equitable health care, including accessible communication. His research focus includes health disparities for individuals with various disabilities, health information accessibility, health literacy, and telemedicine applications. Mike is also director of M-Disability and co-director of the Center for Disability Health and Wellness at the University of Michigan. Mike, please start.
Thank you so much. Thank you for the great introduction, Dr. Harper. Thank you for the team for helping to put this together. So I'm delighted to be here really just to talk about how we can really rethink and address a lot of the ongoing inequities that patients with disabilities have in a primary care setting. And so what I'm going to be doing over the next 45 minutes to 50 minutes is just highlight some of these gaps and some potential strategies that we can do in a primary care setting to address them. So before we do that, I do want to provide some acknowledgements. So this really could not take place without the support of the IDEAL RRTC grant, so Investigating Disability Factors and Promoting Environment for Healthy Living. And this actually was through the support of NIDILRR. So we were very fortunate that we have this support to provide these webinars. And NIDILRR is part of the ACL and also part of the HHS. What we're going to be sharing today does not reflect the views of these groups. So we have several agenda items. So the first one is going to be healthcare barriers for individuals with disabilities. We're going to talk also about communication and health literacy principles, and then review some strategies for reducing inequities and improving identification of patients with disabilities, and cover best practices to improve the engagement and accessibility for these people. And we'll have hopefully an engaging discussion at the end. Again, for objectives, we're going to just review where the barriers are and how they impact the health of these individuals. We're going to explain how communication and health literacy principles relate to these individuals, as well as screening for potential communication barriers and identifying where these break down so that we can target them. And then routinely applying best practices so we can improve getting them engaged and be able to address their clinical needs. So many of you have already seen this infographic from CDC, and I put this out there because it really just highlights how often we see these individuals in our primary care setting. So right now, 1 in 4 individuals report having a limitation or a disability. When you think about the sheer magnitude of this, obviously in primary care, we deal with a lot of the bread and butter like hypertension, cardiovascular disease, diabetes. But even like with diabetes, how much training, how much focus we put in that. We have roughly about 11% of the population has diabetes at this point. We're talking now about people with disabilities is 26%. Now, how much attention we put towards these individuals is really dismal, and really it's just really small, minuscule compared to the amount of attention that we do for diabetes. So obviously it's common, but why is it important? So obviously these individuals not only are going to struggle accessing primary care, these are individuals that are going to have a lot of social economic barriers. They're going to have difficulties finding, trusting a primary care clinician. They're more likely, as a result, to struggle with management of various chronic health conditions. And as a result of that, we'll have higher emergency department utilization and hospitalization. That also includes hospital readmission. So these are individuals that sometimes get labeled as being frequent flyers, burdensome. And what we need to do is we need to avoid these terms. We need to understand that how we care for these individuals is often inaccessible, and we're expecting them to be able to care on their own when we're not even providing the resources to do so. And these are individuals that will struggle with various health conditions. So obviously most of my work is around deaf and hard of hearing. And just to give you, again, the risk for developing chronic conditions among deaf and hard of hearing, when you think about depression, 47% higher risk for having depression. When you think about cognitive decline, it's 24% higher. When you talk about cardiovascular disease, it's 54% higher. So people say, well, I don't really see these individuals. That's not true. We see them often. They're also more likely to have various chronic conditions that we need to not only identify, we need to do a better job of screening for these conditions. So as a result of deaf and hard of hearing being connected with various chronic conditions, this is something we struggle in terms of this cascade of higher costs. We also struggle with higher ED hospitalizations as a result of that too. So this is not a phenomenon that we see only with deaf and hard of hearing. We see this also with physical mobility issues. We see it especially with low vision or limited vision. We see it with intellectual developmental disabilities. We see it also with cognitive and mental health issues. So these are individuals that often will hold Medicaid, public insurance, and they're more likely to struggle with inappropriate healthcare utilization. So obviously this is important for insurers, and I also encourage insurers, policymakers to understand that this is a population that needs more attention across the board, more training, more education, because these are where we can potentially address some of the costs, some of the inappropriate healthcare utilization. So again, how we can be proactive, rethink so that we're addressing them at timely points so that they don't go through these adverse experiences. So I put this again as an example. There's many other examples that you'll see with other types of disabilities. So these are what I just put for really sentinel articles that have come out. So the good news is that we are learning more. Over the past decade, there's more articles coming out highlighting some of these inequities. What we need to do is figure out how we can intervene and get into more of the implementation side of things. So one of the things that a comment that I get from primary care providers is that many of them may have mild forms of a disability that they don't need attention. I would push back and argue that even identifying a disability, regardless of the severity, is really where we need to start acting and being proactive in not only arranging communication access, accommodations, screening for chronic conditions. So the first article here by Dr. Genther actually looked at those with mild hearing loss. We're not talking about severe. So mild hearing loss, 16% higher risk for hospitalization. When you go to moderate, it's 21% higher. So even at mild levels, there's already changes that are happening. Same thing for with Dr. Reed's article. This is using administrative claims. and found that the healthcare costs among unaddressed hearing loss compared to their hearing peers, there was an additional cost of $22,000 higher than what we saw with the general population. And that was over 10 years. So there is a cost component that we need to understand and try to address as well. And in terms of the other one is hospital readmission risk. Obviously, Medicare is very interested in this. When you have communication breakdowns, especially among older adults, they're 32% more likely to be readmitted when they have hearing loss and communication difficulties. So these are individuals that are bouncing back. They may not understand the discharge instructions, or they may have complications as a result. Now, there are ways we can intervene. We can address hearing loss to some degree. And with Dr. Mahmoudi, her article actually highlighted that with the use of hearing aids, it actually can help to lower the risk of ED and hospitalization by 9 and 10% respectively. So there are areas we can actually make a difference here. I wanted to just provide a little bit more context about the disability law. This is an area where a lot of primary care providers don't understand the legal mandates and their responsibilities. Dr. Lisa Hayasoni in Health Affairs recently highlighted this, showing that how little providers know in terms of what they're supposed to do, how to set up the accommodations. So I wanted to just provide a little more context about these three laws. So the Rehab Act, Section 504, was passed in 1973. It's enforced by the Office of Civil Rights. The Americans with Disabilities Act was passed in 1990. That expanded beyond public sector to cover private areas. And that's enforced by the Department of Justice. The Affordable Care Act, Section 1557, was passed more recently in 2010, again prohibiting discrimination in healthcare settings. There were several sections within the Affordable Care Act that were very relevant, and we are still, to this day, have not fully implemented. And I'll share a couple of those in a second. But obviously, providing accommodations and access for our patients with disabilities still remains unaddressed. So I recently had, last year, I had a deaf patient who became a new patient at our clinic. And she came from another primary care provider, was not receiving interpreters. And I received a packet of old records from the old doctor, and I was puzzled. I came across this contract that was signed by the primary care provider and the patient, basically saying that the patient would agree not to sue the primary care provider because no interpreter was provided. So obviously this was a violation of these laws. But again, this happens more frequently than you think. And this is not just about communication access. It's also inaccessible medical facilities, medical diagnostic equipment. So it goes on and on. And in terms of the Affordable Care Act, Section 4203, this is actually trying to encourage accessibility with our medical diagnostic equipment. Unfortunately, we have not done a good job. And so there's already, there's one article by Dr. Frost, and who basically said that this review of a state, basically state clinic registry, this was not just primary care, this was different specialties. And they found that 83% of the clinic bathrooms were inaccessible, 93% of exam rooms inaccessible, did not meet ADA requirements. And then 70% of the wheelchair, 70% actually did not have an adjustable scale or an accessible table. And 87% of the wheelchair users were actually examined in their own chairs. So they were not taken out, which obviously can make it easy to miss for ulcers. And then 30% were actually told by the staff when they scheduled to bring somebody to help you move and transfer. So this is obviously we're doing a poor job in following a lot of these mandates and making sure that these people are appropriately accommodated. The other part is the Section 5307 is really making sure that we do standardized data collection. We don't do a good job in healthcare to identify these individuals so that we can collect robust disability-related data. In addition to that, we also need to do a better job in training the workforce. So there is actually, I suppose, out that we're supposed to train the workforce, and we're supposed to provide training programs so they are more culturally competent. They're able to care for these people effectively. Unfortunately, it's an unfunded mandate and it has not been well implemented. So I want to just briefly just talk about how we can actually redesign healthcare for the patients with disabilities. And I have a few ideas, and would love to hear from your viewpoints on maybe you have additional strategies, and we could share that in the chat and open it up for discussion too. So the first thing is really rethinking how we respond to these complaints, which is really more reactive, but moving away from that and try to be more proactive. So an example would be somebody comes in, wheelchair user, and you have no wheelchair accessible table or scale, or your room that you've been assigned is actually small. And so they're already having difficulties coming into the room. Or you may have a deaf patient, no interpreter has been arranged. And this is a situation that happens more likely than normal. Usually people think, well, all of this is arranged. And in reality, is that what happens is things break down, the providers, staff, patient, caregivers all get frustrated. Nobody wants to be in that situation. So it's important that we need to be proactive, think about, troubleshoot where, and identify where these barriers, where these pitfalls often occur, and try to address them before the patient comes. So we need to really just think, in terms of where they schedule, do the check-in, when they see the staff, when they see the providers, when they do the checkout, do a walkthrough to see where those issues come about. So one of the ways we can do that is actually screen and identify who has a disability. So this is a questionnaire that we got approved within Michigan Medicine, and we're already implementing this at Dexter Health Center. And we're slowly trying to make this universally available for anybody who's a new patient, who has wellness exams, so that we could start to compile this data. And so what we're trying to do is identify who may have a disability and who may have specific needs that warrant an accommodation, or maybe it's just simply to get the provider and the staff to be more aware. Sometimes provider and staff are unaware of a disability, and that can already make things break down, can make it uncomfortable. It can also erode some trust as well. And so this disability questionnaire, we're slowly ramping it up, and I'm hoping that this will be widely distributed across the entire healthcare system. And so we also gathered some information as part of our MyChart Disability Accommodation tab, which I'll show in a second. And we gathered data from roughly about 25 providers and 25 staff members at Family Medicine Clinic and also the Physical Medicine Rehabilitation Clinic. And what we found is that among healthcare providers, most of the time they learn about disability status, one, through an assumption. I see the person, I'm assuming the person has this type of a disability. And number two is being informed directly by the patient. And three, as part of the exam. The staff was a little bit different in terms of, again, assuming that there was a disability, being informed by the patient, and third, as a patient complaint. Something broke down, there was an issue, and they learned that there was a disability. We don't want to go through this. We want everyone to be aware before they even go see the patient. And so that will help to facilitate and not having to sort of do some catch up, try to address some wrongs and issues that come up. So I'm excited. This has really been a labor of love with the Center for Disability Health and Wellness. And it's now it's live through our Michigan Medicine. And this is a disability and accommodation tab. And this is built in part of, as part of the EPIC system. So the goal is to eventually have this be distributed through EPIC, which is our nation's largest electronic medical records software platform. And so what people can do now as a patient, provider, or staff be able to fill out this type of information. And it's always going to be there in the electronic medical record. It can be modified as needed as well. And what's great is that it's actually in prime real estate under the patient's storyboard. So that provider staff, as they open up the chart, they're going to see be flagged with this red text. And this Big Bird patient saying, okay, so Big Bird has low vision, also has some hearing loss as well, and in addition to being a wheelchair user. And then going into this tab, you can actually learn about specific needs or combinations. And there's information you can go into: exception to visitor, may need a clear mask, or they may need an accessible scale for weighing. And so this is exciting, and we're going to be compiling data with this. Again, what we're trying to do is make this universally disseminated through Epic and hopefully with other electronic medical records. And this will help to comply with the Affordable Care Act and standardizing data collection too. The other thing we do at the Dexter Health Center, we have within Dexter Health Center a deaf health clinic, and we were able to start this as a result of a Medicaid match grant a number of years ago. And one of the things that we had to do is to take a step back. And sometimes we're so busy on this hamster wheel and we don't really take a step back to think about where these issues come up. And even though I am fluent in sign language, it's important because as a provider, I need to step back, make sure we talk from a patient lens where these barriers come about. And what we did is we did checklists. So there's a number of them available online, ADA checklists to help provide some sort of a guideline to review and do a checklist. And so what we did is we started with those in addition to getting patient feedback. So we had patients that directly and indirectly provided feedback on where these issues were. And we did a couple walkthroughs as well to see where the barriers, where there are areas that we can improve access. And a couple things came about. One was signage, pointing towards the lab, making sure that's just a simple concept everybody benefits from. And then the other thing was accessible questionnaires. So the Medicaid match was based on a mental health outcomes. So we developed PHQ and GAD-7. We made those available in American Sign Language. And so they're available. Anyone can use them. I'm happy to share those as well. So that was available for our deaf signers. So who may prefer not to do written English, they can actually use that tool. The other thing was using a door knocker. So knocking on the door and there's a light that goes off. It helps to prevent being startled, especially if you're thinking you're changing, you're getting into a gown. So that simple technology was very helpful to make it more of a comfortable environment. The other thing we did is the assistive devices. So we have two of them. One of them is on the bottom of the screen. It's called the Pocket Talker, and it's the personal sound amplification product. We use this available for anybody with mild to moderate hearing loss, unable to get hearing aids. Maybe it's a cost, or maybe there's a reason why they don't want to use them. So that is available on demand. So we can grab them. We can use it with the patient. And that could be also useful, especially people masking. The sound is being muted as well. And then the other one is the Ubi Duo, which is actually quite popular with our front staff. So you could simultaneously type back and forth, hey, can you give me your insurance card? Oh, I don't have it with me. So they can go back and forth. Useful for short exchanges, especially if these patients are seeing me, they don't have an interpreter. This is useful just for a quick check-in. So these are some items that we have. And then always pushing for more accessible exam tables. We have two in our clinic, but obviously more is better so that we're not competing for the same room. So these are some items that we have available. So the second one is this quote that I just really feel is incredibly powerful. And this was provided by the former president of WAMC. And it's a simple matter of social justice and equity that our healthcare professional community mirrors society, also in the inclusion of physicians with disabilities. So when we think about that for a second, so when you think about your healthcare team, it's rare for people to think, oh, there is going to be a provider or staff member with a disability. And that's unfortunate. That's just perpetuated by this ableism viewpoint. But these are individuals that we need to be pulled in. We need to have these individuals in healthcare. They're going to, you want a healthcare team that is actually going to reflect the background of your patient population. And these are individuals, because of their life experiences, it's going to be rich. They're going to be able to sit down and talk at a more personal level and talk about some strategies, coping strategies. Yesterday, I had an individual who has a moderate hearing loss and has to keep taking out hearing aids to be able to use the phone. And so even though he came in for other medical conditions, to be able to show a website for some tools, some assistive devices with Bluetooth that can actually work with the hearing aid. And that made a huge difference. It was probably more meaningful to get that addressed, take away that stressor and allow him to be more proficient with his job. And so it's important to have these type of experiences, life experiences. And this also helps people with chronic conditions too, to have that empathy to work with these individuals. So obviously we need more of these individuals in our healthcare team. Same thing for in medical research. Unfortunately, we're not doing a great job. So Dr. Meeks has done a lot of work around this and has found that despite the passage 30 plus years ago for this Americans with Disabilities Act, less than 5% of medical students. So remember, we have a much larger patient population with disabilities, but only 5%. And for practicing physicians is between 2 and 3%. Now, keep in mind that most of these individuals are actually students and practicing physicians are identifying as having a disability are often due to chronic conditions, or they may be due to mental health disorders. When you actually look at other types of disabilities like mobility and sensory, the number goes way down very quickly. So we have a long way to go, and there's a lot of barriers on why this is. Some of it is a stigma. I've had experiences from certain professors saying, well, if you have a hearing loss, you don't belong here. And so these are things that people encounter regularly with this ableistic type of viewpoint. Technical standards of many of these healthcare professional training programs remain as a barrier. So they're not looking with the accommodation, can you do the job? Is actually, do you have the presence of this disability automatically will disqualify people? So there's areas that we need to change to make sure that we have a diverse team. So fortunately, there's change already happening. There's a number of organizations that are really advocating for this and providing resources for these students, trainees, and providers who have a disability. And so one that I'm currently on the board is for the Association of Medical Professionals with Hearing Losses advocacy group to provide mentorship resources and provide some strategies, coping strategies, and basically to help increase and grow the number of individuals who may have a hearing loss. It's also very useful for people who acquire hearing loss, and we're noticing an uptick on older individuals who kind of age into a disability. And this is great because it helps to provide, tech troubleshooting, some tools, amplified stethoscopes. And so it's been a great resource for many people. Same thing for, there's medical students with disability and chronic conditions. That's another group that we even have a chapter here in Michigan Medicine with the medical school. And there's also several across the country in different medical schools too. So there is a growing upswell, and it's exciting to see this, but we still have a long way to go. If you are interested in listening to other stories from providers, trainees, and students with a disability, I would strongly encourage you to check out the podcast with Docs with Disabilities. There's some really incredibly powerful stories that go really in depth on some of these personal experiences. Some of them are horrifying, but just to help you become more aware of some of the hurdles that many of them have to overcome. So when I talk about diversifying the team, one of the things I always tell people is, let's be creative. Who are other individuals that we can include? And Dr. Stanton did this randomized clinical trial. And what they did is they basically randomized two groups to help older adults who had disabilities. So these were functional issues. They had a number of issues, just basic ADLs at home. And what they found is that this occupational therapist is also a nurse, home nurse, and they added a handyman. And so the inclusion of a handyman versus no handyman, not a surprise. So you have this list of recommendations, how to make your house more comfortable, more accessible. Often you're talking about railings, you're talking about some modification. And so the handyman being there was able to address many of those needs. And so not a surprise, but again, when we think of healthcare teams, we never think of a handyman. We always think, oh, that's somebody else. And but the handyman was really instrumental in improving their functional abilities. It saved money to Medicare. It also reduced emergency department. And this same concept applies to IT. I would love to have more IT support, patient level IT support, like when we're trying to get them to go onto the portal or to use mHealth, use their smartphones effectively. So these are devices getting onto virtual visits. So these are all things that we need to have additional help, and providers, staff sometimes are not the answer for those kind of things. So the other thing is also making sure that we can train the team. So obviously attitudinal issues are still something that we encounter both within and without outside. So obviously society, again, we talked about ableism. So that's something that we see across society. It unfortunately is something that we encounter often within the healthcare profession. And so that attitude is something that is rampant. Dr. Lisa Iasoni, I mentioned earlier, talked about how little awareness or knowledge on the legal mandates and some of the responsibilities to provide accommodations. What they found is that roughly about 85% of the healthcare providers viewed those who have a more severe form of a disability as having a poor quality of life. So they view these people as having horrible lives, undervalued, and it's just what it does. It makes them be perceived as less worthy. And so we need to push back. We have lots of people with various types of disabilities, different types of severities are actually doing incredible things. So we need to expose them and understand that this is, obviously having a disability. Many people are happy, they're doing well, they're successful. We need to expose the healthcare team to understand that there's this range of abilities too. And then accessibility, despite the passage of the Americans with Disabilities Act 30 plus years ago, we still are encountering frequent barriers within our healthcare setting. And that's unfortunate. But in terms of, I mentioned the story about the interpreter. So I had a contract saying, you're not going to sue me. Well, there was another article that found that 87% of family medicine providers did not provide an interpreter to their deaf signing patients. And what was shocking is that roughly about 83% perceived that their communication with the patient was good. Now, there's a disconnect. Obviously, you don't know the language, yet you're rating communication quality as good. So obviously, we're not doing a great job, regardless if it's hearing, mobility, if it's intellectual. And then certainly for awareness, we need to make sure that we have training programs to be able to help staff members, providers to understand, become more culturally humble and also competent to be able to care for these individuals. So here in Michigan Medicine and also throughout a couple other groups, there's, again, some increase in the curriculum training programs that are now available. I'm excited. Here we were able to launch the Disability Health Elective. And so we already at the end of our second year. So we've already had several classes of medical students go through this. This is an elective, and I would love for this to be a mandatory part of the curriculum. But so it's a free elective that they can, we have students that could rotate with a number of faculty experts, whether, again, if it's cognitive, hearing, different types. So they get a broad immersion working with different types of patients with various disabilities. The second thing we also launched just in the past year is the American Sign Language course. So we provide language training, but the key part is not so much the language training, is helping them to understand legal mandates, how to communicate effectively, the cultural competency, learning about the culture. Those are the parts that I really feel is going to be more effective for these students. And then, of course, the Ohio State actually has curriculum spanning all 4 years, which is really rare and unique. And so Dr. Haverkamp has been leading that. And then lastly, I wanted to talk about the Deaf Strong Hospital program, which is a really clever immersion program. So I used to be involved with it a number of years back. So this was a program where first-year medical students are now the patients. The deaf community members are now the staff and the providers. So all the staff and providers are signing to the patient, and the patients are the medical students who only know English. You can imagine everybody's confused, things are breaking down, they're frustrated. And what it is a role reversal exercise to really just show that communication accessibility is so vital, and we need to make sure it's there. And then, of course, here with Dr. Sandra Hearn at PMR here at Michigan Medicine has courses available for first and second year medical students. So I'm starting, it's exciting to see some. We still have a long way to go. And these are really sort of hit and miss, mostly electives, but hopefully we can make this a standardized part of the curriculum. The other thing I wanted to just talk about how we can be inclusive. So by being inclusive, we have to think about some of the equipment, facilities, services that we provide. So one, sometimes I'm contacted to provide some feedback in hospital and ambulatory care settings, mainly for deaf and hard of hearing individuals. A common one that comes up is a nurse call button. So in a hospital, you press it and then this nurse speaks to you. You have no idea if someone heard you. Obviously there's no video. And what if you're not able to speak to the call button? And then again, is somebody here? Is somebody coming? And so we've had some injuries as a result because there was no communication through that device. So we need to, again, rethink how to make this universally inclusive. So one of the exciting things coming up is the My Bedside initiative taking place here in the inpatient side of Michigan Medicine. Everybody's going to get an iPad. And so there's going to be text chat capabilities. There's going to be capability to do a video, connect with interpreters, get to know your team, be able to look at your labs, to make requests. So it's going to be much more interactive. That's an example of how to be more inclusive versus this old-fashioned nurse call button that even I would be excluded from. And so it's important to think about your equipment. Is it equitable? Is it flexible? Is it simple to use? Is information, is it intuitive? Is it easy to perceive? And then what's your tolerance for error, the size, and how difficult it is to implement. These are basically sort of guidelines to think about when you have universal inclusion, universal design and inclusion principles. So the other thing that's important is health literacy and communication. Obviously, plain language, a lot of the health literacy principles on graphics, bolding, making sure you highlight important information is all valuable. And I strongly encourage you to do that. But you need to understand that you have to have the accessibility set in place before you even think about the other components. So I had another deaf individual, this was roughly about 5 months ago, who came for a checkup. And we did a medication review, and we talked about atorvastatin, which is a cholesterol-lowering medication. And she proudly told me that she drinks a tall glass of grapefruit juice every morning with the medication. And so for those of you who are not aware, taking grapefruit juice with this medication it's a dangerous interaction. And so you're going to increase your levels of dangerous, even toxic levels. And so we talked about why she thought it would be a good idea to do grapefruit juice. And she told me that the pamphlet bolded the letters, and she did not read the do not use. She just saw the bolded letters of grapefruit and grapefruit juice. And to her, since she signs, did not have good literacy skills, that was to her a message that she should do it. And so she also told me that she had no ability to communicate with her pharmacist. So again, it doesn't matter how phenomenal your pamphlet, your medical information that you're sharing in a print material, if it's not accessible, it doesn't really matter. So that same thing applies when you're giving print materials to people with low vision. You need to think about large print. You need to make sure it's accessible for those individuals too. Same thing also for videos. If it's not captioned, it can be a credible video, but if it's not captioned, you're missing out a large group. So obviously the COVID world has hit us all, but it has been particularly difficult for people with disabilities. There has been also opportunities for innovation and kind of rethinking. And so one of this is actually the use of a clear mask. And so I even have the clear map here. So we tried to implement this universally in our clinic. There's been some pushback, but it's important that we need to think about having this all the time. When you think about for hearing loss, people with communication disabilities, you're already talking about roughly about 15% of the population has a hearing loss. When you add other communication disabilities, you're now moving up to 1 in 5 are going to have some difficulties. So instead of waiting till the patient complains, why not have that available for everybody to use at all times? And so fortunately, we do have FDA approved. The one I showed you, it's a safe and clear, which is on the top. They were the first to get approved. The second one is the clear mask. Some interpreters like it because of the wider viewing. The fit, to me, it's a little bit awkward. There is a third one, which is some people like as well. It's the face view, which has a emergency use authorization, so it's not completely approved. We do not have a clear N95. Ford has a prototype, but it has yet to be approved. I know they've had it available for the last couple of years. And so this is an example, again, universal design and inclusion principles. Instead of just waiting till you have a need, why not just always use it? And this benefits everybody. There was a study that came out noting that patients liked their providers better when they could see their face. They also felt that their communication quality was better. There was no difference in terms of what was shared. And this was among a group of no hearing loss. And so the point is that there's a gain by using this for everybody. So same thing also for virtual remote services. So the virtual visits, again, it gave another opportunity for disruption, improved access for people who have transportation barriers, which has been phenomenal. But it's also, we had to push for the inclusion of CART and captioning. So sometimes things move forward, but don't really get the feedback from patients with disabilities. And so we're always sometimes trying to catch up. So it's important when you think about a virtual visit, you need to think about the captioning. So we're able to use live transcript, which is kind of like an auto transcribe through Otter AI. So it's an artificial intelligence, auto captioning. But you can also insert captioning like what we have today, where you can have a remote captionist available. The other important thing is if you have a deaf signer, or if you have a caregiver, or you have, trying to think if you have like a medical student or somebody, you can do multi-way video visits, and making sure that you have the capability to do that will allow for an equitable virtual visit. What we've noticed is that sometimes it's just two-way, you're excluding people, and then often you have to do a phone, and there's going to be communication breakdowns. As part of the disruption, prior to COVID, we never had remote captioning available in our clinic. that's changed. And you can look at the picture on the left, where now we have a remote captionist on an iPad mounted on a mobile pole, and now people can request that as well. So despite the challenges, there are opportunities too. I want to just kind of wrap up here so we can have some time. So integrated care models is one not easy to implement, and some of this is because of the reimbursement models are often go against this. But I do firmly believe that integrated care models are really a large answer to address a lot of the inequities that we see with patients with disabilities. There are models often around behavioral health. They have been the leader on this, but there are integrated care models with dentists, with oral health, with primary care. There are primary care working with rehab specialists. For example, we have Courage Kenny at Minneapolis. There's an example there. Intellectual developmental disabilities, another big one where there's several models across the country. They're few and far in between, but we need to try to promote this. We did this model also as part of the Medicaid match and had a sign language fluent social worker who was our behavioral health specialist. It was a great team because dealing with deaf and hard of hearing individuals, lots of psychosocial issues, and be able to work with the behavioral specialists to complement what I was able to offer really helped to address a lot of their psychosocial needs. They also improved their depression and anxiety scores. And so obviously we need better expertise. With the inclusion of virtual visits, I can see easily where we have these regional hubs where we can have hopefully areas where you can not only do in-person, but also do virtual visits with possible consultation for primary care as well. But we need to make sure that the reimbursement model is there. The sustainability is often the biggest threat for these type of models. And we need to get more training to include more primary care providers interested in disability health so they could be part of this team too. So again, I'm just gonna wrap up. Often patients are the expert. We need to work with them. We need to be culturally humble. Often it's okay if you don't know, just let them know, let them teach you, and be willing to learn as well. So I'm gonna wrap up here and see if there's questions.
That was awesome, Mike. Thank you very much. To our participants, please type your questions in the Q&A box at the bottom of your Zoom window. If you must use your audio, click on the raise hand button on the Zoom window and raise your hand and let us know, and we'll be able to ask you. We'll unmute you and let you do that. And at this point, we will start with some questions.
So the first one here is ask and provide slide. So if a patient self-identifies a disability but has no official diagnosis, can a patient still request accommodations? Absolutely. So the way we had a skip logic where they could say yes or no, but we do understand that not everybody identifies having a disability. And so they skip if there's any needs or accommodations for their visit. So there is an option for that. And I totally agree. That is an important component too. And then the second one, what was the name of the podcast that was mentioned? So this is Docs, DOCS with disabilities, and it's available online through our website. And then can you talk about best practice alerts and enhancing care? So we are currently doing a project that's involving patients with physical disabilities and trying to address some of the care needs. So obviously they have a higher risk for diabetes, yet primary care often does screening for diabetes, usually following general population parameters. We don't want to do that. If they have a physical disability, you need to be screening for diabetes at the onset. So these are individuals 66% more likely to have diabetes. So we need to be more aggressive with the screening. So the BPA is actually a smart step because there's several components, allows to prompt and do like clinical decision tools to encourage primary care, these are family medicine providers, to select and order these type of things. Same thing for bone density. So we often think about women 65 and older, unless there's some exceptions or risk. Same thing. These are individuals, if they're having issues with physical disabilities, cerebral palsy, they have osteoporosis at a much younger age. So we need to be more aggressive. We did the first sort of the reason we pursued this path. We had a similar best practice alert that involved, do you think you have a hearing loss? So encouraging primary care providers to ask patients to help identify and facilitate a referral to audiology. So that was our first one that was led by Dr. Philip Sasso, and was able to not only do a better job in identifying these people in the problem list, but it also helped facilitate referral. So the referral was really low. We went from like 0.5, we were able to get it up to, it was roughly about 5%. Same thing for the problem list, really dismal, 2%. We were able to identify, I think, closer to 11% in our data. So those are some examples there. And then the next one, I'm a medical student at an institution where disability is not integrated in our curriculum. Do you have advice on how to advocate for inclusion at an institutional level? This is a national problem. So I appreciate this comment. I would recommend to reach out to one of us so we can actually share some of the things that we're doing, curriculum. There are some resources being developed. You will probably notice that many of us are happy to try to share those resources, try to advocate for you. I would also join medical students with disabilities and chronic health conditions. They are a great advocacy network, and I've noticed other locations are now starting to be more inclusive for disability-based curriculum as a result of the advocacy of the medical students. So you actually make sure you network, but I've been incredibly impressed by our medical students here advocating for a lot of these type of curriculum. So I would encourage to check them out and perhaps partner up and try to push back. The next one is, if a patient has a disability such as mobility, can a scheduler allot additional time for a Michigan medicine visit? So the scheduler, no, but what we do is we can make that comment, relay it to the primary care provider, and they can, say, yes, we can add additional time. I think most primary care providers will appreciate that, so that we're not falling behind during our clinical sessions. And usually they will welcome that kind of opportunity. Thank you, Patricia, for adding the podcast.
Mike, there was a question that came up in the chat, which said, what role can physicians play in helping patients with disabilities develop positive attitudes towards their disabilities?
Yeah, so I think a lot is also by having a diverse team, you are automatically going to help show that, we belong, we are here, and learn some coping strategies, learn some of the, assistive devices that we include. So I think it's slowly changing, but making sure that there's opportunity to see your leaders, you see your providers, to see other people at, at a very advantaged kind of position to do those kind of things that look like you. I think there's nothing more powerful than that. So I think that could be one way to make it more positive.
In your clinic experience, Mike, are there particular exams or are there particular topics that you find easier or more difficult to discuss with patients who have various disabilities? So
I think it's really important to, even for myself, to always ask what your needs are. So I think it's a good reminder for us. Sometimes I do forget. We have to be careful not to make assumptions. So obviously, because I do also sign, I had a deaf individual who came from, it was actually an immigrant from an Eastern European country, came, and he actually was preferred to do written English, did not know sign. And so it was a little weird because I kind of pushed back not to write or not to type out things. But yeah, that was what he wanted. And so it's important to, again, I talk about that cultural humility is important. Let them lead. And, sometimes you have to actually give them suggestions, but make sure that the patient, remembering that they, because of their background, their experiences, often can be the expert. I don't, and there are other situations where there may be other types of disabilities, and I'm not the expert on it, and that's okay. We have a growing number of various types of disabilities coming to our clinic, partly because of our emphasis on communication, the disability competency. And so it's important to state, I'm not an expert in this. I'm happy to learn more about it and to also reach out to other specialists that can help.
This has been awesome. I really want to say thank you to all of our participants, especially to Dr. McKee. We're now finished with the Q&A session and we're about out of time. But we have learned a lot. We've learned a lot about the research that has happened, the research that needs to be done. We've shared strategies about making healthcare more inclusive and equitable. You have brought up questions about how to do this in your own home institutions. And those are fabulous. Those are the places we want this conversation to move to. We really want you to continue thinking about either new questions or new innovative ways we can address these issues. Please provide your feedback about the webinar in the Qualtrics survey linked in the follow-up emails that you'll be receiving. There will be a YouTube recording about the presentation, and the slides will be made available and accessible as soon as possible. So again, we thank you very much for joining, and we thank RRTC and all of the people who've made this possible today.
Thank you.